how to assess a patient with ACL or suspicious ACL injury. The presentation today will be having a learning outcome of physical examination is essential for prior ACL reconstruction, using the right image, X-ray, MRI, or CT to assess. Also, we'll talk about the graft failure mode and the tunnel position and necessity for bone graft when you plan your procedures. So clinical assessment, it's always important to listen to the patient and see how it has happened, especially if they tell you they have difficulty in twisting and turning or pivoting in deceleration. They participate in sports such as football, basketball, racquetball. These require a changing directions. So we need to listen to the patient. How did this injury and what is the injury affecting them? Athletes who have difficulty with these should be evaluated for ACL. Preoperative history, as I said, we need to know how long, mechanism of injury, symptom. If somebody has a surgery before, we need to know the surgery date, the technique, the graft choice. Getting the operative report from the previous surgeon is important. What is the fixation method? And if there was an associated injury or other surgical procedure. Postoperatively, how the rehab was done, and if there was any complications, and when he returned back to sport activities. And if there is any recurrence, what is the date? How far since the surgery? How did it happen? Again, you need to know what other symptoms like instability or stiffness, knee fusion. These are important when we assess the patient, whether he has a partial tear or full tear, or if he has other concomitant injury like meniscal tear as well. Then we need to check the wound. Maybe they have an infection. Maybe there's a sinus. We need to see the scar. We need to see if there is swelling or there is a muscle atrophy. And we need to know about the alignment and gait. It is very important because any alignment issue will affect the surgical site. Palpation, we need to look for temperature, refusion. You have to go back to basic. These are essential procedures and need to be evaluated properly. You need to check the range of motion and knee strength and to assess if the patient is hyperlax. That's very important when you choose the graft choice in these cases. And to avoid, especially in revision case, to avoid doing the same mistake. Here, I remember a case that done by a surgeon who used a hamstring in a hyperlax patient, which ended up to an early failure. And then he revised it by taking another hamstring from the other leg, which doesn't work for the patient again. So choosing the right graft is important and assessing the patient is important. If we need to go for the special test, we know the gold standard is Lachman test. And we also need to assess for rotational stability, for a pivot shift test, or mediolateral varus and valgus, and assess the meniscal with, for example, the McMurray's test. Imaging, we need to get AB standing view. We need to get a lateral view in 30-degree flexion to assess the slope. We need to get a Marchant view, as well as a standing PA at 45 knee flexion. What we are assessing, we assess the lower limb alignment, we see a slope, position of the tunnels, tunnel widening, and fixation method, degree of knee arthritis, and any associated disability. We see a slope, Dr. Nadro will talk about, which shows increased tibial slope greater than 14 degrees, increase the stress and reconstructed ACL, and that will cause an early failure. So if we look at this young man, 32 years old, who have a gene of valgus and increase what they call recurvatum, as he doesn't know why one leg is hyperextended than the other. And when you talk to the history and you ask this gentleman, he will tell you that when he was 13 years old, he had a proximal tibia fracture, which was treated conservatively at that time. And if you see this, you can see that he has a reverse tibial slope because the fracture healed in malalignment. So if you try to do an ACL alone without correcting his alignment, it will not work. And if you look at, which is a very rare, having a tibia valga, most of the time we have our valgus malalignment in the distal femur. In this case, because it's a post-traumatic, the tibia healed in the tibia valga. So to correct his alignment, you need to do biplanar osteotomy and the proximal tibia to correct his valgus and to correct his posterior slope. So you need to get biplanar closed wedge osteotomy, and in this case, at the same time of doing the ACL, or it can be staged in a different time. So alignment from here is very important, as you see, and most of the surgeons, they just jump to the MRI directly without going through the other assessment tools. So MRI, yes, we need to assess fusion, to assess graft preservation, tunnel preservation, if there is any cartilage damage, if there is meniscal injury. Sometime we need to get a bone scintigram to see the degree of the arthropathy, or if there is a complex regional vein syndrome, or if there is a suspicious of infection. CT scan will show us the bone abnormality and the previous tunnel size. In case of revision ACL, we need to assess the position of the femoral tunnel. Most of the failure is due to the wrong position of the femoral tunnel. If you can see the picture on the right, the femoral tunnel is too anterior, and that causes an impingement of the graft. So we need to get to know about the graft choice, allograft versus autograft, soft tissue tendon versus bony tendon graft, and ipsilateral versus contralateral. We need to assess what type of technique we need, all arthroscopic versus inside out, single bundle versus double bundle, transtibial versus transportal. We need also to see, we need to remove any hardware using fluoroscopy or universal set of instrument, and other procedure like HTO, or do we need to treat the cartilage, meniscectomy versus meniscal repair or transplant, posterior lateral corner injury, and also medial collateral ligament. Looking at this again, it says the tunnel is vertical and anterior, which lead to a widening and failure. Another one, the same vertical femoral tunnel, or posterior blowout of the femoral tunnel. In these cases, maybe you need to change from the interference screw to a suspensory fixation, like a button. Again, here, the problem now in the tibia, if you look at the tibial tunnel, is too anterior, and that will stretch on the graft and lead to early failure as well. If you change the biomechanics of the knee, the graft will limited either inflection or extension, and that will lead to early, to creep and early failure. So we need, in case of revision, to assess the tibial widening to see if there is a need for a bone graft or not, or using a BTB or not. So it depends on the pathology. You determine your treatment. So in summary, physical examination is essential prior to ACL reconstruction. Image tools, X-ray and MRI and CT to assess. And we need to know the graft failure in case of revision and tibial position and necessity for bone graft. Thank you.